Hello, my name is Srdan Verstovsek. I am professor of medicine in the Leukemia department at MD Anderson Cancer Center, Houston, Texas. Today, I want to speak to you about polycythemia vera. We're going to analyze a case of inadequately controlled polycythemia vera. Our patient is a 68-year-old gentleman that has a 3-year history of polycythemia vera. He was diagnosed based on erythrocytosis, thrombocytosis, and a JAK2V617F mutation presence. That was at the time when he had unprovoked deep vein thrombosis. He was treated with low-dose aspirin, phlebotomy, and hydroxyurea since then. He did very well, but now he presents today with complaints of fatigue, pruritus, and occasional night sweats. His hematocrit, however, has been well controlled, and the goal is to have hematocrit below 45%. Our findings are included here. Hematocrit is very well controlled, below 45%, but his leukocytes and platelets are elevated. He has no blast on peripheral smear. He is iron deficient, as judged by decreased ferritin and low MCV. He has normal chemistries, and his physical exam reveals splenomegaly of about 5 centimeters below left costal margin and about a half-inch wide malleolar ulcer on the left leg. The bone marrow biopsy was done. The fibrosis is not markedly increased, and he has normal cytogenetics. Now, how do we define resistance or intolerance to hydroxyurea in polycythemia vera? There are 5 factors to account for that are outlined here. These range from continuous need for phlebotomy, uncontrolled myeloproliferation, presence of splenomegaly, or cytopenia or non-hematological toxicity. This is, of course, in the light of a good dose of hydroxyurea for a good duration of time. Experts in the field judge to be 2 grams per day of hydroxyurea for at least 3 months of exposure. Now, how often does this happen? Frequency of resistance or intolerance was studied in Spain in about 260 patients, and a median time to resistance is about 6 years, while time to intolerance is about 3.5 years. And therefore, it doesn't happen right away. It happens in about 12 to 13% of the patients, either resistance or intolerance, and it takes time. When we talk about intolerance to hydroxyurea, we have here a data from the very large study that is very important to analyze. This is in about 3,500 patients in Italy. And the most common side effect of hydroxyurea is, in fact, an ulcer on the lower part of the leg. This is around malleolar ulcer, as in our case. 9 out of 10 patients that have intolerance to hydroxyurea, in fact, have mucosal or cutaneous ulcers. Other rare side effects are pneumonitis or fever. What do we do about polycythemia vera in everyday practice? The first-line therapies are interferon or hydroxyurea, and hydroxyurea was used in our patient. In older populations with a short life expectancy, busulfan can be tried. Now we have a new development in polycythemia vera with approval of ruxolitinib. It's a JAK inhibitor which is approved in the United States and Europe in patients with inadequate response or intolerance to hydroxyurea. So what happened to our patient? This is a 68-year-old gentleman who was found to be intolerant to hydroxyurea because of the presence of the ulcer on the skin on his left leg. Therefore, we prescribe him ruxolitinib, 10 milligrams twice a day, as is uniform starting dose. Unlike in myelofibrosis, 10 milligrams twice a day is a starting dose for all patients with PV. The patient had very good response in symptoms, and the spleen and the leg ulcers was healing. His blood cell count normalized, and he continued to live with a good control of signs and symptoms of PV. This case illustrates 2 aspects of possible inadequate response to hydroxyurea in therapy in PV. Intolerance, that is a skin ulcer, and resistance, uncontrolled myeloproliferation and presence of systemic symptoms, despite controlled hematocrit. In about a quarter of the patients, we can find these findings. And ruxolitinib is now a new option for therapy of such patients, as it can achieve good control of blood cell count, spleen, and symptoms in patients in a second-line PV. I would like to thank you very much for listening to this presentation. Have a nice day.